Alright guys, so for this week's topic I have urolithiasis, which is basically just the formation of stones. So they can either happen in your kidneys, they might happen in the bladder, it could happen in the urethra. But basically what it is these stones that your body is trying to pass through by excreting them through your urine. So the stones are deposits. They're made of minerals that can crystallize from concentrated urine in your patients. So you're definitely going to want to, on assessment, ask them about how much fluid intake they have. So upon assessment, your patient is going to be in extreme pain. Usually these stones don't present with any symptoms until your body is trying to officially pass them. So the pain's going to be acute. It's going to be in the side, the flank, the lower abdominal region, the groin. They're going to be having frequent urination. They may not be passing as much urine. With all the frequent urination, it might be in small amounts. They can have hematuria. The nausea and vomiting can be from the pain as well. Again, that's going to be something you want to incorporate on your assessment of, what is your patient not only intaking for fluids on the average, but how much have they been losing through nausea and vomiting. They may also present with diaphoresis and fever as well. So the calcium stones that your patients may put out, there's 4 types of them generally. The first would be calcium stones. It's calcium oxidate. It's from a diet high in calcium. It usually just occurs naturally. They have struvite stones, which are indicative of infection, like UTIs. They grow really quickly. They grow largely, and your patients are going to have that acute pain that brings them in. There's then uric acid stones. Those usually happen through dehydration. Either your patient's not taking in enough fluid or they're losing too much fluid. So as we know, your kidneys are your fluid regulators, so that's where you get those uric acid buildups that crystallize and form the stones. We then have cystine stones. They're the ones that tend to be hereditary. Again, on your assessment, you're going to want to make sure you're asking about family history of stones. But what's happening is your kidneys is putting out too much of cysteine, which is an amino acid. So going back to risk factors, of course, family history. Is your patient dehydrated? Do they eat a diet high in protein, salt, or sugar? Obesity, of course, like everything else, risk factor. Digestive diseases such as irritable bowel, maybe if they've had gastric bypass, these can actually cause a risk factor for urolithiasis as well. Also, too, if your patient has a history of hyperparathyroidism, they tend to have an increased risk for kidney stones as well. So we're going to want to monitor their blood and urine testing. When they are urinating, you may have them filter the sample. That way the stones, as they start to pass, can be collected and examined for the type that they may be, what they're made of. If the stones are tiny, we can send them for a CT, but usually general x-rays will show them passing through. You're definitely going to want to manage your patient's pain. They're in a lot of pain. Increase their fluid intake. They may need IV fluid, so we're going to definitely want to monitor INOs on these patients. The doctor might prescribe an alpha blocker. So what those are going to do is work to relax the ureter muscles to make it a little less painful for these patients to pass urine, to pass the stones. And then we're going to want to educate the patients too, of course, after the whole process is done. Make sure they're drinking plenty of fluids throughout the day, eating a low salt and low protein diet. With these patients, you're not going to want to have them cancel calcium altogether. Just, encourage the calcium-rich foods, but have them use caution with any kind of calcium supplements that they may be taking. And that's it.